as we think about getting back to normal, it's not going to be getting back to normal. It's going to be getting back to hopefully something better than normal and something that is more rational in terms of our care.
Welcome to MedAxiom Heart Talk, the podcast where thought leaders come together for one ultimate goal: to continually transform and optimize cardiovascular care for all. MedAxiom Heart Talk starts now.
I'm Cheryl Toth, host of MedAxiom Heart Talk. Last week, many states began a cautious and steady move toward relaxing COVID-19 restrictions that have been in place for the last few months. Guidance and reopening dates vary by state, and members continue to contact MedAxiom with questions. They're also posing them to colleagues on the listserv. We're responding with ongoing updates to MedAxiom's COVID-19 resource page, which you'll find at medaxiom.com/COVID-19. And there you'll find webinar recordings, the reemergence playbook, our telehealth coding tool, and links to all kinds of guidance documents. MedAxiom consultants add to these resources regularly, so check back at least once a week. And here on MedAxiom Heart Talk, we continue to bring you insights from the front lines by inviting guests to share their experience and lessons they're learning during the pandemic. Joining us today is cardiologist Dr. Edward Fry. Dr. Fry is calling in from Indianapolis, where he's chair of the Cardiovascular Service Line for Ascension Health and a practicing cardiologist at St. Vincent, Ascension, Indiana. Dr. Fry is also a board member of the American College of Cardiology and MedAxiom. Thanks, Dr. Fry, for joining us on MedAxiom Heart Talk.
Great, thanks for having me.
So let's start off by kind of the overview of what are some of the biggest challenges that you and your colleagues at St. Vincent are dealing with right now as you all work toward reemergence from the COVID-19 restrictions.
Yeah, so I think it's best to think about what reemergence really means, and some people have termed it as return to normal. I think it's hardly that. It's really two things, I think. One is to reengage patients and get them the appropriate care that they perhaps have deferred. Obviously, we've seen the tragic consequences of increased number of MIs at home, and then presenting too late for reperfusion therapy, same thing with strokes, and other chronic conditions that have been deferred to a point where creates an acute problem. So that's one aspect and probably the most serious. The second is the more elective or what I think is a better way to term planned care as opposed to elective care, and making those tests, procedures that are part of the chronic disease management of patients with chronic heart disease, whether it's congestive heart failure, coronary disease, arrhythmias, or the like, and creating the circumstance that makes it safe and appropriate for them to return. I think the biggest obstacle, and certainly in the first instance, is the concerns regarding patient safety and the risks that they might incur in terms of being exposed to COVID and contracting COVID, and by definition, since they have an underlying cardiovascular problem in most cases, a recognition that could be really a devastating consequence. And then further beyond that is just the whole confidence in terms of whether it's at the hospital level or whether it's at the office level, that those safety precautions are maximized and that their risks are minimized. And then I think there's a very realistic obstacle that I'm afraid we're going to see more and more of, is an economic one, as we see the economic consequences of COVID hit, and we see people lose jobs, lose insurance, and even if they don't lose their insurance, the specter of high deductibles that they may have to pay now in a true financial crunch become real obstacles to access. And those are things that we have to recognize and deal with and talk about directly with patients.
So as you are working toward dealing with these three issues, are you looking at the Indiana state guidance or CDC or Ascension Health? How are you getting your arms around those challenges in your organization?
Yeah, so the easy answer is all of the above. And obviously, COVID and the world after COVID is such a dynamic one. The recommendations, the resources, the information change hour to hour. And not only in terms of the guidance and the recommendations, but also then the resources available, whether it's testing or PPE or other parts of patients' care that are in short supply. So they have to be modified at a local level based on general consensus guidance. Obviously, CDC guidance is more general and public health oriented. We have guidance from the various professional societies, including ACC, and then further subspecialty societies. And then within our system, creating standards, but recognizing those standards have to deal with the realities at the local level. The mantra that we've used recently has been as standardized as possible, but as different as necessary. And so we're having to tailor some of the recommendations regarding, and I know we'll get into this later, specifics regarding testing and how that relates to pre-procedural evaluation and triaging of patients.
As standardized as possible, as different as necessary. I like that. You started this, you mentioned, I asked you about the challenges, and the number one you said was reengaging patients to get the care they need. So when it comes to reaching out to those CV patients who've avoided care due to their concerns for safety, what are you doing? What are your plans for bringing them back and making them feel comfortable and safe?
Yeah, I think there's three levels of approaching that. One is the inherent blocking and tackling that needs to be done with respect to creating the safe environment, screening of patients, education of staff, both temporal and geographic spacing and distancing within the offices and hospital systems, all the sort of logistic issues, the appropriate cleaning, all of those things. The second is trust, and I think that's a critical issue. And although you can't go back and reinvent trust, I suspect that practices and patient-clinician relationships that had been trusted and strong in the past are of great value today, because the patients will look to you in terms of having their best interest and helping them make the best decision for them. Mm-hmm. And then I think the third part, which is probably the most important, is patients understanding their cardiovascular risk and how that fits into the paradigm of deciding, is their risk related to COVID exposure, infection, and complication offset by their cardiovascular risk. I think a good way to think about this, or statistic to think about, is that probably we don't know exactly what the final mortality count from COVID will be, but based on estimates, I think it's fair to say that there will probably be about 5 times as many people who die from heart attacks each year as who will die from COVID. And that needs to be put into the perspective of what the individual patient's risks are in terms of what they prioritize as the most important thing in their overall care.
So let's talk about some of the specific things that are on people's minds when they come in, and also certainly staff and physicians. There have been a lot of questions on the MedAxiom listserv about mask requirements for patients and N95 availability and other PPE for techs. So most people have replied on the listserv that they are requiring masks for patients in the office, and they provide one for those who don't have it. And some folks started talking back and forth, what happens when patients refuse to wear a mask? What do you do? So curious how your organization is handling this for the patient side, and then also talk a little bit about what you're suggesting for techs or requiring in your practice.
Well, the middle part of that question, the issue about patients refusing to wear a mask, I mean, obviously we're dealing with a select population, somebody who's made a decision already to access the medical community. So they're sort of of the same mindset. So fortunately, that's not been a problem. We would politely decline care for that patient and try to make other arrangements, obviously try to work with the patient and educate them as to why it's not just them, it's also others, and it's the entire care team that we have to also take into consideration. We are using universal masking. That's been a policy we have adopted both at the hospital and the office level. We do allow patients to use their own homemade masks. There's some obviously scientific concerns that maybe they're not fully protective, but they fill another need, which is just sort of awareness and making patients realize that they're in this environment where we're trying to mitigate the risk of infection. Right. And then lastly, with respect to the issue of specific masks and staff and techs, in a perfect world, I think we probably all want the most protective equipment that we can, but we're having to deal with being rational about how we allocate those valuable resources. Hopefully with increased production, more and more will come online. We have set out for specific procedures, specific testing where N95 masks and who in terms of in the room would be wearing those masks. We do take into account the level of PPE for all testing and want to do that in a way that's maximally protective to the patient, maximally protective to the staff, but also cognizant of the limited resources that are available.
Great. Another common and very popular topic since the beginning of all this has been telehealth and virtual visits. And we've focused on coding for telehealth in recent episodes of the podcast. And, there's the coding tool on the resource page. But with regard to operations, now folks are starting to ask about what is the best way to accommodate in-person and virtual visits in the same schedule with providers? And there have been various ways of doing it. Somebody mentioned that their goal in the beginning was to designate blocks. You block all your virtual and block all your in-person, but that really didn't work. So what are you finding works best? What are you settling into as far as a pretty good effective way? Because you mentioned before we started recording that you're doing virtual visits. How is it working for you and your colleagues?
Yeah. So we have 2 large practice sites in Indianapolis, and then we have a network of satellite practices and offices around the state. So we have a total of about 8 practice centers, which means that we have about 9 ways of doing that. So the short answer is that this is certainly a work in progress. We are implementing our reopening of the office practice in a phased approach. We have 3 phases over the next 6 weeks where our goal is to transition from 30% face-to-face and 70% virtual in the first phase, 50% of each in the second phase, and then 70-30 opposite ratio in the third phase. And we truly believe that will probably end up becoming the optimal ratio, if not even 50-50 perhaps in terms of virtual versus live in-person visits. In terms of logistically, there's several things that we're taking into consideration. So we again want to limit the number of patients who are in a given area at any one time to temporally space them in addition to creating social distancing. And so to accomplish that, we have tried to stagger inpatient and virtual visits as best we can to reduce that burden of people who might be in the waiting room or amount of time that they'd have to wait in the waiting room. That will become more of a challenge as we get to these higher ratios of patients face-to-face versus virtual. So that certainly will need to be worked out. I think eventually we'll get to a point where we will move to blocks, and hopefully that will occur at a time when perhaps infection prevalence in the community is less, and so in theory risks go down, but still practicing social distancing and all the protective measures, that will be more efficient. I think we will have days when, or parts of days where physicians may be off-site doing their virtual care. And the beauty of virtual care is they can do it anywhere. So that could be maybe when they're at a satellite clinic or an outreach clinic. So it doesn't matter really where the patient is. They can see that patient anywhere. So I think there'll be some flexibility built into that, but certainly to be worked out over time.
Well, so tell me about the three-phase plan. How do you have a timeline for that? Is that going to be 3 phases over the next 6 months or so, or less?
Less, and certainly guided by the facts on the ground, particularly
right.
The infection rate, and this is a place where the testing information published by the state health departments can be directional, but sometimes confusing. Because if you think about it, as we expand testing, we will anticipate to see that there are more positive cases. That may or may not be the best measure of disease activity in the community. Hospitalizations and certainly ICU use and sadly mortality rates are probably going to be more objective measures of what the actual disease activity is. And as we know, a positive test means that there'd been exposure about 2 weeks ago. If there's a hospitalization, that was about 3 weeks ago. And if there's a death, 3 to 4 weeks ago. So we have to be very careful about looking at the data, looking back and using that to decide the speed with which this transition takes place. But to get back to your original question, yes, this is a phased plan over a 6 to 8 week period of time, and we're just launching this right now.
Well, and I think it's interesting that you've got these targets for the virtual care, because I think we can all agree that virtual visits is something that is definitely going to change long term. But going back to a 70-30 and thinking about it like that, where were you before COVID-19 in terms of your delivery of telehealth visits? Was it at 30% previously, or will that be more?
Gosh, no. I think like most, certainly had obstacles with respect to coverage and availability and technical issues. We actually supported 2 nurse practitioner run cardiovascular practices in rural areas, mm-hmm. and used telehealth as a sort of internal consulting method. Our advanced heart failure group certainly have used remote care and some elements of telehealth in terms of managing VAD and complex congestive heart failure clinics around the region over time. But a very small piece of our practice, I would say, well below 3%. So,
big change. Let's talk about the staff and the physicians. How would you describe the current well-being of folks that and how at the stage we're at, and as you think about maintaining that well-being over time, what are you and your colleagues talking about?
Yeah, well, I would say the short answer is that been extraordinarily impressed and proud of the entire staff as well as the clinician community. Obviously, those on the closest of the front lines, and certainly pulmonary critical care docs and advanced practice providers have borne the brunt of the COVID inpatient surge, and then critical care oriented cardiologists and procedurals, particularly interventionalists, is sort of the next tier. But I think everybody has approached this with a common resolve of a sense of duty and professionalism that has been incredible. Now, to our hospital and systems credit, I think they've helped facilitate that through engagement, bringing the physicians in as the really the decision makers, thought leaders in terms of the planning, and then the acute care during the surge, and then in the reemergence, and really working in a collaborative way rather than sort of a top-down way. Tremendous support. We've been very fortunate that there's been tremendous commitment to keeping the care teams intact. and not to be eliminating jobs and to be furloughing. We've used a strategy of redeployment and reduced hours, use of time off to help mitigate some of those problems. And then just to be very a transparent level of communication between administration and clinicians. Some would say too much communication. I think we all feel like we're bombarded by emails and webinars and things like that, but I don't think you can over communicate in this circumstance. So if I were to prioritize those things, I think it's really sort of the recognition that, the clinicians need to help lead in this circumstance, as we've been fortunate enough in the past to be able to do. Now it really becomes important, and that just engenders so much trust that really helps with well-being. There is the burnout fear, and not fear. I mean, it's reality, and we've certainly seen it around the country, and we've seen it in its worst forms in terms of suicides and mental health issues. And again, I think that comes back to number one, a recognition, number two, level of support, and, recognizing getting people out of a situation that's going to perpetuate or foster that, get them the right help, get them the right support. Very difficult problem, and something we'll probably see more of going forward. But, I think health systems and practices and hospitals, they understand what true well-being in this circumstance is about, and the threat due to the intensity of the whole COVID process. Fixing it's more difficult. Recognizing it is the first step, and trying to address that. So it clearly is an important thing that we think about and that we try to address as best we can.
Well, I have to believe that this sort of this underpinning, you said, not focusing on furloughs and laying people off, but figuring out how to do that. So how to do things. So maybe it's increased time off or things like that, so that folks feel secure in their job. I know that I hear a lot of that, the fears of losing a position for non-physicians are real out there. So that in and of itself, I think, builds trust and a feeling of feeling like the organization cares about me as a staff person. And you mentioned the burnout, and of course the fact that the temperatures are warming and summer's here is going to mean that maybe some folks are ready to take some time off. There was discussion on the listserv last week. Somebody posed the question about, hey, is anybody modifying their travel policies? What happens when somebody on the clinical team in particular wants to take time off, and when they come back? Have you talked about that at this point in your organization? Any changes to your policies?
Not so much, but if I could just go back to, one of the points related to what you were commenting about, seeing the sort of the personal financial concerns to the care team members. I was just reading an article just before we got on here about, obviously the economic devastation to healthcare has actually been disproportionate. As an industry, healthcare is down more than any other industry, mainly through losses in not only revenue, but high expenses related to the care of COVID patients. So there's real, struggle, real concern, real risk of survival of some hospitals, practices, and even systems, and that weighs on the well-being of
people,
and the security aspect. I think the most vulnerable in our systems obviously are those who are at the lower end of the pay scale, and those people are also going to be the most critical to our ability to rebound. I mean, if you don't have the office staff in place, the MAs in place, the RNs, the techs, the pharmacy people, the transporters, you can have all the clinicians you want, but you won't be able to get anything done. So recognizing that, keeping that secure and building that will be important. With respect to the travel issue, I think we haven't made any mandates, but we try to educate people to be thoughtful in terms of I'm not sure I would plan a trip to New York to go to Broadway right now without a mask on, but I think you do want to encourage people to take the time that they need to get away and stay healthy mentally and in terms of their resilience, but to be sensible. And I think fortunately most people they understand that and implicitly.
Yeah. I think we'll take a break on that note. Good place to stop, and we will be back in just a moment. Stay with us for a conversation with Dr. Edward Fry. MedAxiom is proud to provide its membership with the Cardiovascular Care Reemergence Playbook, designed to help you navigate the new normal created by the COVID-19 pandemic. This playbook provides expert guidance from MedAxiom, coupled with resources from government, societies, trade groups, industry, and MedAxiom members. The goal is to provide you the latest information in a single, interactive, and easy-to-use platform. Over time, we'll build out resources at every level of the cardiovascular care spectrum. Check medaxiom.com/COVID playbook frequently for the most current information and resources. That's medaxiom.com/COVID playbook. We're back on MedAxiom Heart Talk, and we're speaking with Dr. Edward Fry today, Chair of Cardiovascular Services at St. Vincent, Ascension, Indiana, about how his organization is planning for a new normal during the COVID-19 reemergence. So, Dr. Fry, let's move over and talk about procedures. MedAxiom conducted an informal survey on the listserv and received 22 responses to this, and the vast majority are indeed conducting COVID-19 testing prior to a procedure, with most of those are doing PCR testing. How is St. Vincent handling pre-procedure testing, and how many hours prior to the procedure are you performing it?
We have put together an algorithm based on the type of procedure or inpatient tests, ranging from open heart surgery to stress testing, and tiered those in terms of level of need for testing. Obviously, things that are going to require an inpatient stay typically are going to require testing, and typically PCR testing 72 hours prior to the procedure. Currently in our market, the availability of rapid testing is limited, and number of tests are limited per day. So we're having sort of a hybrid approach to that. We've modified recently our testing algorithm related to things such as cath or things that would not be considered aerosol producing, particularly catheterization if they were low risk, and especially if they were anticipated that they could be a same-day discharge even with PCI, to relax the need for testing simply because of the availability and the delays that is incurring. Very few of our procedures are truly elective, and the ability to wait, it has to be balanced with waiting for testing and for the all of that information to be gathered. It has to be balanced with the risk of waiting for the procedure. We are doing screenings of every patient in terms of their symptoms and temperature, and asking people to, once a test or a procedure has been scheduled, to self-isolate until the procedure is done. For things like stress testing, where there is a lot of debate about what the risk of aerosolization is, but we're erring on the side of stressing patients with masks on. We're not testing everybody who has a stress test unless they are otherwise fail screening or otherwise in high risk groups. But certainly for things like TEE or ablation, where intubation may be necessary, we are doing testing prior to the procedures.
Well, and some folks are sharing on the listserv that their pharmacists are suggesting to use medication only for the exercise treadmill stress test.
Right.
And how are you feeling about that? Kathy Biga pointed out last week in a post that some patients really need the exercise, and what she kind of asked, what are people doing? There were 6 questions she asked, and folks were talking about it. What guidelines do you have in place at St. Vincent? How are you thinking about this?
So the default is to use pharmacologic nuclear perfusion stress testing, particularly regadenoson or Lexiscan, as a first line. And I'll come back to some of the concerns related to that may not be present now, but in the future. But secondly, Kathy's right. I mean, there are going to be some instances where particularly stress echocardiography is needed, particularly patients with valvular heart disease or other patients where you really need the physiologic information. Mm-hmm. And so in those patients, we are taking the precautions of masking during exercise. The technician was closest to the patient having an N95 mask and taking those PPE precautions. Other things that can be done in terms of this particular patient population with where the issue is myocardial ischemia that would not require stress per se, also includes adenosine stress MRI and CT-FFR with no stress, where you're looking at the physiologic consequence of the anatomy by CT. So those are some alternatives. One concern that certainly comes up is, and we're sort of in a little bit of this honeymoon period right now, where in many cases prior authorization has been waived for testing like nuclear perfusion stress testing, which is in the past always been a battle getting those tests approved. Fortunately, right now, not having a battle, but as I think some of the moratoriums expire, and most of them were 90 days beginning in the beginning of March. So we're going to be coming up on those beginning of June or early parts of June. It's going to be interesting to see how payers handle this. There's a lot of work going on from an advocacy level, both through MedAxiom and through ACC, with letters that have been put together by, I know, Athena Pappas, president of ACC, and by leaders from ASNEC and other ASE and other societies to ask for an extension of relief in this area, because this is being done as a patient and staff safety concern and should not really become a financial concern. And if you think about it, the payers have been making hay during this period of time. Their expenditures for care has been dramatically reduced, yet in most instances they've been collecting premiums. So they're in a financial position where they could easily accommodate that. And so hopefully those advocacy efforts will be successful in sustaining our ability to choose the test that is safest for the patient and the staff.
That is a great point. That there's some runway that they've got there to be able to continue that, and during this post-acute period of COVID. I also want to circle back on, you talked a little bit about the PPE for techs during and staff during the exercise treadmill testing, the N95. Several were talking about techs being a little bit nervous in all different tests, echo, PV, sleep tests. So how are you deciding on the PPE? Somebody mentioned, are you using N95s only for select asymptomatic patients felt to be at higher risk, the surgical mask for routines with goggles? So what are your thoughts on the masking of the staff to keep everyone safe?
Mm-hmm. So our position has been to use N95 for the staff closest to the patient, so the tech actually with the patient on the treadmill or performing the echocardiogram if it's in the setting of stress echocardiography. And fortunately, our supply has been such that is something that we can do, but that is a big concern. In many ways, although we risk stratify people in terms of what their COVID or infection risk is, I think we need to be pretty realistic that our ability to predict that is pretty poor. And to make the assumption that anybody could be potentially infectious is the way to approach things, and that's what we have done. And then I think educating the staff as to optimal precautions, educating them, making the case that, this test is being done not out of just, where this is just what we do, so we're going to do this test, but really a thoughtful approach that this is really necessary and we're really going to use this information from the test to alter care. I think when we have that buy-in, that becomes, hopefully alleviates some of the fear. It may not change the realities of what the infection risks are, but then to take every precaution that we can with the assumption that patients can be infectious.
Yeah, absolutely. Are there anything else you'd like to share about procedures and PPE? Anything else going on there at Ascension that's a lesson learned or anything in particular?
Well, I think in many, until we have better tests, obviously PCR has, depending on the type of test and the numerous ones that are out there, the lack of standardization, there can be anywhere from, 30 to 40% false negatives, fewer false positives, more false negatives. And same is true with antibody testing until we get some of the more reliable tests that have been specifically approved by FDA, not just the emergency use authorization, the EUA authorization of the many different tests that are out there and fairly useless. Until we have real confidence in those, I think the goal is going to be using PPE as the line of defense. And that obviously necessitates that we make sure that our supplies are used judiciously, appropriately, and that both from the federal, state, and public sector that we have enough production. And to get back to the issue of, don't do a test unless it's going to affect the care of that patient. I think this is that movement to value that we're really beginning to see, and for many is a different philosophy of care. And as we think about getting back to normal, it's not going to be getting back to normal. It's going to be getting back to hopefully something better than normal and something that is more rational in terms of our care.
Well, and to that point, Dr. Fry, what do you see as the biggest hurdles to watch out for over the next 3 to 6 months? Where are we headed, and what should folks watch out for?
So I think there's probably three things: 2 medical, 1 non-medical. The two medical things are disease activity in the community. If we start to see reemergence of infections or hot spots or spikes again, that's going to require a change in approach and a pulling back and a reconfiguring what we're doing. And then the second part of that, the second medical aspect, goes back to the patient confidence issue, which certainly would be tied to the first of those points. And then I think the third, and which I think will end up being probably the more influential, is what the state of the economy is going forward. If we truly head into depression type environment, the impacts on access, on ability to provide care, solvency of hospitals, viability of practices could be really challenged. And I think we need to recognize that the economic cures are going to be equally important to the medical cures.
I think this is a great point. Final advice, Dr. Fry, what would you like to leave cardiovascular physicians and leaders with today?
Keep doing what you're doing. I think the medical community and cardiovascular medicine in particular have, really been exemplary in terms of putting patients first focusing on what is best for them, and then likewise a renewed appreciation and recognition for the importance of our staff, and really sort of changing the centricity, I think, of how we view healthcare. I tend to be very optimistic about things, and maybe to a fault, but I think we'll definitely come out better for this. Over what time frame, I have no idea, but I think this will really allow us to positively transform care, really looking more towards value. It's going to make us re-examine every aspect of our care, not only the logistics, but the care algorithms, clinical care pathways. I think we'll see guidelines that'll take into account aspects that have been raised through COVID, including cost effectiveness. So I think it's the beginning of a whole new era, and physicians can you can either sort of passive observers, or you can be leading the process. And so far, we've seen clinicians lead the process, and I think that can only be positive in terms of their professional satisfaction. I think it is definitely a positive with respect to the potential for burnout, and it can only be good in terms of creating the best type of care delivery model for patients.
So well said. Great. Dr. Fry, as always, we appreciate your insight, and we are really grateful you could join us today. I know that you have a really long list of priorities and patients, and are glad you could take the time to talk with us on MedAxiom Heart Talk. Thank you.
My pleasure.
And thank you, everyone, for listening today. If you like what you hear on MedAxiom Heart Talk, please refer us to a colleague. They can find us on Apple, Google, and many other podcast apps. If you've been enjoying our program, please take 2 minutes to review it on your podcast app. That really helps us out a lot, helps people find us. Or if you'd prefer to give us feedback directly, send an email to hearttalk@medaxiom.com.